Let's get out of the shoulder and focus on around the shoulder. The talk wouldn't do justice to what not to miss. The title should be what to look for and keep on looking. So that's the first question. So A is true and B is false. B is false, okay? And both are false. The third option is very less. Okay, let's go to the next slide. So the house believes that rotator cuff cannot flex and abduct the arm above 90 degrees in the absence of deltoid. Okay, this is a 52 years young man, sustained proximal humeral fracture, not exactly the fracture, the tuberosities were off, and probably had a dislocation because he had a brachial plexus injury. Sorry about this. So we have already answered this question. So this is a 52 years young man who sustained a tuberosities fracture and probably a fracture dislocation of the shoulder because he also had brachial plexus injury. I will show you the X-rays right now, but the surgeon went with the intent of fixing the tuberosities, but missed it. 5 months later, greater tuberosity was fixed and brachial plexus neurolysis was done. Suprascapular nerve recovered, but axillary did not. So no deltoid and no teres minor, and presents to me 2 years later with pain and dysfunction. This was the original X-ray of the injury. He also had fracture right femur, which was fixed, and this fracture was also fixed like this. Maybe it flew off later on. Maybe the surgeon did have the sutures through the plate and whatever, but the tuberosities did not stay there. 6 months later, tuberosities were fixed and brachial plexus neurolysis was done, but axillary nerve did not recover. So this was the axillary view which I had gotten. This was the patient with deltoid wasting, and you can see the 2 incisions of the original surgery and then the brachial plexus neurolysis and GT. So we said the deltoid absent and cuff cannot elevate. There is no deltoid, no axillary band. That's the abduction. He can go even further. And if cuff is there, why there is no external rotation? And if infra is intact, why there is ER lag? No deltoid. And no teres minor. So deltoid extension lag test was positive. And the Bertelli's test was also positive, which is supposed to be the most specific one. And this is a short video. I will rather try to run it fast if I could. But he had sulcus sign, a multi-directional instability kind of picture. I can't go on to this video. Can you help me there? Anyway, I'll skip that, but he had good internal rotation in this video. So what next? What would the house want me to show in terms of investigations or further plan? But pain and dysfunction, Ashish. No external rotation, as you've seen, I mean, not in 0 degree abduction, not in 90 degrees, and pain. So I have the MRI, NCV, and a couple of more tests. This was the MRI. So you can see the pristine cuff. There is no cuff tear. But do you find anything abnormal on this MRI axial cuts? I can come back to this slide later on. Exactly. That's one point. 1 point, tuberosity was fixed, but look at the position of these screws. They are not lateral. They are sitting where the bicipital groove is sitting. Yes, that is also there. Anything else? Yeah, that Shirish said. Yeah, you could, because if you see the axial views of the X-ray, there's a little piece of bone also gone majorly with the upper edge of subscap.
Posterior.
Exactly. So the head seems slightly posteriorly subluxed.
Yes.
So we have picked up all the three things which are important on this axial cut. And MRI, T1 Sag, and I mean, this T1 Sag is a bit confusing, but I'll come to the detail of this later on. But no serious fatty infiltration of the cuff. That's the electromyography done by the most competent man in Delhi NCR. He confirms chronic axillary nerve lesion and no evidence of upper trunk or radicular lesion. And that's, I got his kinesiology done for the scapula. And as you can see, the left scapula is externally rotating just to compensate for the lack of external rotation. So this is a paper which was published in 2017, shoulder function in patients with deltoid paralysis and intact rotator cuff. 27 patients followed for even more than 5 years. They all had pain, but the only point was they were able to lift. They all maintained shoulder function with average abduction of 131 degrees, flexion of 153 degrees, and AER1 and AER2 rotations in both adduction and abduction to the tune of 58 degrees, which is a very good function. And in such paper, they say that because the function is good, you don't need to do anything. Of course, pain was there on a scale of, because they had a different scale by Cofield and Neer, which was 0 to 4, and the patients had pain at the level of 2. So if we go for VAS scale, you can extrapolate it to level of 5 or 6, and they didn't do anything for the patients because despite the pain, but because the patient had external rotation. Now, deltoid muscle contribution to shoulder flexion and abduction strength and experimental approach. This is a recent paper published in JCS. They blocked the axillary nerve, ultrasound guided axillary nerve block in 12 patients, and then they were able to study the effect of deltoid to the flexion and abduction and rotation. And they found out that deltoid shows a linear contribution. As the abduction and flexion angles increase, deltoid contribution keeps on increasing. So deltoid is much more effective at this point rather than this point. And internal rotation strength was not disturbed by the deltoid paralysis. And deltoid and teres minor contributed 53% to the external rotation strength in 90 degrees abduction. Another paper, and this was a paper, the previous paper projected that deltoid contribution increases by the angle of abduction, and this was an axillary nerve block. The next, Gerber had done this experiment by blocking the infraspinatus and supraspinatus by blocking the suprascapular nerve differentially at the spinoglenoid notch and at the upper region, and he said that infraspinatus palsy alone produces 70% of external loss of 70% of external rotation strength, and infraspinatus and the supraspinatus combined lead to a loss of external rotation strength of approximately 80%, and a loss of abductor strength of approximately 75%. But the important point in Gerber's paper was that this did not depend on the angle of abduction. So Gerber even went on to say that we do the Jobs test at 90 degrees, and Gerber says you can do it at 30 degrees, and we are practically doing it at 60 degrees in scapation, not exactly 90 degrees many times. Do you agree, Ashish? I mean, we are assessing the supraspinatus at 30, 60, 90, and Gerber had said that in 2007. So there comes my next question. What do you think is the cause of lack of external rotation? Shirish and Ashish spoiled the game. They picked up the defects. So I confirmed with my radiologist, and in fact he pointed out to me, Raman, the infraspinal looks too much wrapping around the humerus, too much stretched anteriorly. It looks too much overstressed, and of course the posterior subluxation of the humeral head. Now the next question: how should we manage this patient? Sorry, it's not a packed major to deltoid. It's packed major to clavicle, inverse plasty, and even distalizing the attachment distally. That's what we've done. It's not just that we flipped to deltoid. It was reattached, flipped completely to the clavicle, lateral clavicle, and the distal attachment was distalized by 1.5 centimeters. So it was a bipolar kind of a fixation to the anterior deltoid. Because that's a nice one. And I persisted, and I told the patient, okay, look, this has been taking too much. So I advised him so many opinions, and he went around for every test, and he waited 1 year, and he comes back, okay, let's go ahead and do it. So I was not sure myself. So I spoke to Basim. I sent everything to Basim, and Basim did confirm that he has 10 patients of dynamic posterior instability presenting with this much, and that is what he said. And he agreed with the concept that yes, we need to do something for the overstrained cuff. We need to do something because he'd already done anterior deltoid inverse plasties bipolar for his deltoid paralysis. So he said, I think that will be a reasonable plan because of lack of external rotation. So this is what I did.
Dr. Raman, your last 3 minutes starting.
Okay, so I'll skip the videos. So we did the packed major inverse plasty and distalized the insertion of packed major onto the humerus as well, and the arthroscopic debridement and biceps tenotomy, and lower trapezius transfers with hamstrings to the GT. I didn't do the lower trapezius to infraspinatus because infraspinatus is ineffective functionally anyway. So this is what was done. So I'm just skipping the video. I've skipped the video. I took the help of my plastic surgery team, and we did this. That's the completed inverse plasty. And then we did the lower trapezius transfers. I did an open acromiotomy because there was too much scarring all around, and it was not worth at the time because there was too much of was going on. So I split the acromion like Basim had described and brought the my fixation of the hamstrings to the GT there. And this is at 4 months, so better appearance, no sulcus sign, functional improvement, regained pre-operative range of movement. So by Hippocratic oath, I have not done any harm. He's regained whatever he had post-operatively. Pain is still there. It's marginally less, but he actually says that pain is almost like that, not increased, maybe a little bit less. So pain has not gone. And let's see the function. It is still very early days. I had him for 2 months. He was in an aeroplane, kind of a splint. So he's regained the elevation. He's little bit, only a jog of external rotation is there. Internal rotation is preserved, and the lag sign is a bit less as compared to the pre-op. My talk is over, but I would like to thank my radiologist and my plastic surgeons and Basim for